Welcome everyone. We will get started here in just a minute or two. We're just admitting a few more folks in the waiting room or from the waiting room, and then we'll get started. As we are getting started, if you'd like to introduce yourself in chat, place your name and what organization you're with. That's really helpful as we get going. And all right, it looks like our waiting room has slowed down, so we will go ahead and get started. However, if I look a little distracted, it's just because I'm glancing over at that waiting room to get folks entered into our webinar. So welcome to today's webinar, Shorter is Better, Optimizing Antibiotic Prescribing to Improve Health Outcomes. KFMC Health Improvement Partners and the Kansas Department of Health and Environment's HAI-AR section are pleased to host this session in recognition of U.S. Antibiotic Awareness Week. So I am Loretta Fitzgerald, and I'm a Quality Improvement Advisor with KFMC Health Improvement Partners and today's facilitator. Please do make sure that you are muted throughout the presentation, and you may submit questions in the chat at any time, and we'll address them during the session as appropriate or at the end if time allows. Any unanswered questions will be sent or followed up by email post the presentation. So this session is being recorded, and the recording and slides will be emailed afterward. While C&E credit is not offered, you may request a certificate of attendance through the post-event survey that will appear when the webinar concludes. I am thrilled to introduce our presenters for today, our co-leads for the Antimicrobial Stewardship Program within the KDHE HAI-AR section, Dr. Megan Klatt and Dr. Kelly Wark. Dr. Megan Klatt is an infectious diseases and antimicrobial stewardship clinical pharmacist at the University of Kansas Health Systems in Kansas City, Kansas. She received her Doctor of Pharmacy degree from the University of Michigan College of Pharmacy, and then she then completed her first year pharmacy residency at the University of Wisconsin Health, followed by her second year residency in infectious diseases at Michigan Medicine. Her practice and research interests include both inpatient and outpatient antimicrobial stewardship, gram-negative resistance, and antimicrobial pharmacokinetics and pharmacodynamics. Dr. Wark is an assistant professor of infectious diseases at the University of Kansas Health System in Kansas City, Kansas, as well as the subject matter expert on antimicrobial resistance and the co-lead of the Antimicrobial Stewardship Program within the KDHE HAI-AR section. At the University of Kansas Health System, she serves on the Antibiotic Stewardship Committee, the Vaccine Task Force, and co-leads the Ambulatory Stewardship Subcommittee with Dr. Klatt. So thank you, ladies, for sharing your expertise today, and we're excited to learn from you.
Thank you, Loretta. And my computer just for some random reason just froze. So hopefully I'm not having any issues so far. So hopefully no ongoing internet connection issues. But if so, Megan certainly is capable to take over for me if I disappear. Okay, so thank you guys today. So we're so excited to talk about Antibiotic Awareness Week, and we have some exciting news this time. If you want to go to the next slide, Loretta.
Oh, maybe. There we go.
So we got an in-person signing this year with Governor Kelly. So this is our 8th year that we've celebrated the Antibiotic Awareness Week in Kansas. And so we were so excited that we had an in-person signing with our governor. And then you can see our whole team there and our partners as well were able to make it. I said 8th, but I guess it was 7th. So sorry about that. If you want to head back to the objectives, I just couldn't wait to show our picture of the governor. So today basically we're going to kind of go over like really antibiotic durations. And so there's this new mantra called shorter is better. And this is really kind of within infectious disease and antibiotic stewardship is a really has turned into a huge part of our objectives in our programs. And so we're going to review kind of the the evidence and the data around these shorter durations and basically kind of get everyone up to date and talk about clinical practice, how we can hopefully shorten some of these courses. And then we're going to also, as part of this, discuss the outcomes associated with these shorter durations. And I didn't include it here, but a big part of what Megan's going to talk about at the end is some resources that we've actually been working on, some posters and some new kind of updated symptomatic pads and a social media campaign. All right, next slide. And there you guys go if you want to look at it again. Okay, so the power of antibiotics. So it's so easy to take antibiotics for granted, but just look at this graph. So this is the pre-antibiotic era. So 100 years ago, we're looking at what people died from various types of infections. So a simple pneumonia, about a third of people ended up dying from that. 10% of people, if had a skin infection or a cellulitis, they died from that about 100 years ago, which is crazy because, that's even a higher rate than what people go into the hospital today with a heart attack. So today, more people back then, more people would have been dying for skin infections, pneumonias than what today's rates are dying from strokes and heart attacks. So just such a powerful impact on medicine. And so what we really need to recognize is this power and make sure that we can continue to sustain these really life-saving medicines for as long as possible. Next slide. So the 5Ds are really these core principles when we refer to antibiotic stewardship. So the right drug, the right dose, the delivery, so the route, whether this is an IV or oral, and then de-escalation, and then the 50 is duration. So this is a core principle of antibiotic stewardship. You all know that antibiotic stewardship, by getting these 5Ds, by getting all these right components, our whole objective is to really optimize our antibiotic prescribing and our antibiotic use. But the outcomes are that it does reduce antibiotic resistance. Also, if we're having more appropriate therapy, we're going to have less side effects. We're going to have less adverse events. There's also association with decreased length of hospital stay. Certainly, that follows reduced costs. But our ultimate goal for all of this is to improve patient outcomes. Next slide. So you guys have probably seen this slide. I use this. I love this study by Malhotra and colleagues. So this is an example of how quickly antibiotic resistance develops by just being exposed to antibiotics. So what they did was they gave one group an antibiotic, so a macrolide, either a Z-Pak, so azithromycin, or another type of macrolide, and then they had a control group that basically wasn't exposed to any antibiotics. What they did is they swabbed their throats for 28 days, really going all the way up to 42 days. So you see, by as quickly as day 4, the group that was getting that Z-Pak or that azithromycin, they'd already increased their amount of strep pneumococcus that was being recovered from their throat by fourfold. So within 4 days, fourfold increase in the streptococcus that was resistant to that antibiotic they were getting, versus those people that didn't get any antibiotics stayed pretty stable, as you can see in that bottom part of the graph. And this was followed all the way up to actually 6 months. So really, again, you use it and you possibly lose it because those bacteria are then selecting for resistance. So the ones that are able to survive that are the ones that then we have growing. So other things that the antibiotic use contributes to, so prolonged hospitalizations. So especially with people that have more drug-resistant infections, antibiotic-resistant infections, you're going to have longer stays, sometimes up to 20, a quarter of the length of someone that didn't have a drug-resistant infection. Costs are substantially increased. 29% is the average, but if you're talking about super resistant bugs, you're gonna be tripling, even tenfold increase in those costs. And then actually antibiotics are our number one associated adverse events where people go to the ER. So, if they're getting an antibiotic, if people develop a rash or they're developing diarrhea, out of all medications, people are going to the ER because of an adverse event from antibiotics. So again, another costly kind of endeavor. And then we're all aware what can happen from the antibiotics as well. So collateral damage, like we're wiping out our good GI flora, and then we get C. diff that overtakes it. Next slide. So this is a really interesting article by Rice. He published it in Clinical Infectious Diseases a good 15 years ago, but it kind of goes over the history of durations. And it started out being really interesting. So we all know that, penicillin came out in the 1940s, 1945, 44, 45. Really when Fleming even, accepted the Nobel Prize, he at that point already warned on the possibility of resistance developing. But interestingly, when people started to use those penicillin courses, they generally used 1 to 2 days. So 1 to 2 days was curing pneumonias. At the most, they were treating 3 to 4 days. So really, really short courses. We then started to have all these antibiotics being developed, called the golden era of antibiotics from the 1950s onwards. And so part of this also was the pharmaceutical manufacturers were really advertising this. So why would you want to sell 1 to 2 days of antibiotics when you really could do 14 days, 28 days? I mean, they're making money if they're getting more durations, right? So a lot of these durations that emerged throughout this period were really not based on any evidence. It was based on what the drug companies were trying to advertise and to encourage clinicians to use. And there was a lot of drama and a lot of scandals that actually happened. So the FDA director of antibiotics was actually he actually was also the editor of Antibiotics, and he of a journal called Antibiotics, Antimicrobial Therapy, and was actually getting a cutback to do more pharma ads on antibiotics, and so there was just all this, like all this kind of stuff that was going on. At that point, the FDA really wasn't in charge of determining, safety or efficacy. What they really worked on is safety. So as long as this medicine wasn't causing any major, adverse events, they would pass it. And so this emerged, like all this stuff was happening. The pharma industry was putting out huge advertisements about, use this to, had a session yesterday talking about some of these crazy ads, encouraging mothers to like, give antibiotics to their kids so they'd calm down. But it was really getting like out of control. And so there then started to be kind of this, the FDA really started to turn around and started to look more at the efficacy. And there's kind of this revolution where they really cracked down on this. And now, really, as resistance started to emerge, one thing that's come out is really focusing on these durations. And so you can see that since really in the past 2 decades, we've had over 120 randomized control trials, kind of examining these durations for a variety of different infections. And that's what we're going to talk about today is this kind of literature around these types of durations. Next slide. So in Brad Spellberg, he's an infectious disease out of UCLA. He's the person that's kind of have this mantra of shorter is better. And he had a really interesting article where he published and kind of brought it up that, had Constantine, who developed a 7-day weekday, instead said, we're going to have 4 days of a weekday, not 7 days. Might our antibiotic durations be 4 days instead? Because as you'll notice, we're mostly tending to give week-long antibiotics. So that skin infection, that pneumonia, we'll give 7 to 14 days. But why do we do 7 to 14 days? It seems like it's based on just, the average week. So he had a really interesting article if you guys want to check that out. Next slide. So the first one we're going to talk about is ventilator-associated pneumonia. So we'll start kind of from the more of the inpatient type of infections and move towards, more of like the outpatient, where you'll see more outpatient infections. But ventilator-associated pneumonia, this is definitely an inpatient scenario. This one traditionally got around 10 to 14 days of antibiotics. These are a couple studies where they compared shorter duration, so either 8 days or 6 days compared to about a 2-week course. You can see that both of these studies, they had the same outcomes, meaning both groups were cured of their pneumonia. There was no increase in mortality. And they actually looked at this mortality rate up to 2 months. So they studied it pretty far out. And actually, they really didn't have any recurrent pneumonia increases. There is a caveat on that one, but in general, the shorter durations for ventilator-associated pneumonias pseudomonas or VAPs did not increase. But what they saw was they had less side effects because if you're getting half the course, chances are you're not going to get diarrhea, or you're not going to get a rash, etc. And the other thing they found specifically in VAPs is that it cut down on the amount of drug-resistant infections that it created. So they were about a third less likely to develop any colonization with these antibiotic resistant infections. Next slide. So this is just a couple extra studies. If you, I'm not, not going to belabor the point, but there's more than those two studies. There's several other studies that have looked at this, including some meta-analysis. The one caveat, next slide. There is one caveat, and that is Pseudomonas. So, the Pseudomonas is the one that there was in some of those studies, not all of those studies, but a couple of those studies that showed that there was possibly some increased rates of recurrent pseudomonal VAP if they were treated with a shorter durations. Not every shorter duration, but there was a trend that maybe that was happening. So the guidelines actually do still say 7 days is appropriate, but if the patient is not improving very promptly, if they're having, persistent fevers, if they're having persistent respiratory failure, if they're having, persistent infiltrates, not able to get them off of the ventilator, that's a scenario where you probably wouldn't want to do the shorter 7 day, and you would probably want to look at it doing a little bit longer. Next slide. Next slide. So next is community-acquired pneumonia, or CAP. Similarly, this is the one on the left is a randomized control trial. So they looked at people that got the shorter duration of 3 to 5 days versus the more traditional 7 to 14 days treatment. And this was actually over 30 systematic reviews that they looked at these randomized control trials, over 18,000 people, and they actually showed no difference in the amount of cure. So if you got that shorter course, you had as much likelihood of being cured as if you got the longer courses. So there's not as much literature looking into the CAP regarding their amount of drug-resistant colonization and actually surprisingly adverse events. This study on the right, this one where they gave high-dose amoxicillin and it was a shorter course, so it was 5 days of high-dose amoxicillin versus 10 days of normal dosed amoxicillin. They actually found that shorter duration, even though it was higher dose, was associated with a decreased rate of drug-resistant pneumococcus. So, again, the longer courses you're just providing more time to expose those bacteria, so you're carrying with it a greater risk of resistance. Next slide. More evidence, again, not going to belabor it, but if you want this for clinician citation or more evidence, feel free. There is a lot of literature out there. Next slide. So even interesting, this isn't standard of care, but this is just something I'm going to bring up, is atypical. So the things that you're thinking that might, like a pneumonia from Legionella or Mycoplasma, typically, we would give 3 5 days. This study actually compared giving azithromycin, again, a big dose, so 1.5 grams instead of the typical 500 milligrams that we would give. But actually, they found 98% cure in each group. And this group also was followed a fair amount of times. They were followed up to 4 months or to 4 weeks, and didn't show any increased rates of recurrent pneumonias or needing further antibiotics to treat. This is definitely, like I said, not the standard of care, but this is just, again, showing that there is more literature that is coming out that is suggesting that we can cut back on these durations. Next slide. So there are some scenarios where you're definitely probably not going to want to do the shorter durations. So if, say, you had someone on an antibiotic that wasn't treating what they had recovered, so you were treating them with ceftriaxone, and they ended up having, say, MRSA or something that was resistant to that, you probably aren't going to want to count the Rocephin as your shorter course. So if you had initial therapy that wasn't active against it, basically, if you're getting extrapulmonary infections outside of that, if you're getting meningitis, if you are getting, obviously endocarditis, these other kind of things that are more complex, that's not looking at a shorter duration. If you had an abscess or if you have an empyema too, those types of scenarios, you're not going to be doing a shorter course. Those are going to be scenarios that really requiring generally probably like weeks of therapy. Next slide. So the next one we're going to go over is sinusitis. And so generally, most sinusitis really are viral upper respiratory, and really, a minority, less than 2%, are caused by bacterial. But as we know, everyone that has a sinus infection and that has pain more than a week is definitely, pretty convinced that this is a bacterial infection that needs antibiotics. This, a lot of studies that also have shown, this is overdiagnosed. People come in and they do have pain, and so we want to do something about that, just to help with their symptoms. But it doesn't mean that they're going to have symptomatic improvement because we treat them with something that is not going to cure what they have. Megan will talk about it in a little bit, but we have these symptomatic scripts that really go over kind of some therapies and some medications and some stuff that can actually help with that kind of symptoms instead of the antibiotic that probably really isn't going to do anything for them except maybe drive some resistance. There was a meta-analysis, so they looked at 17 of these trials, and they were blinded. So the patients were blinded, the clinicians were blinded, and they actually gave these people, and these were people that they had diagnosed with sinusitis, and actually bacterial sinusitis, not the viral, and they gave them antibiotic course, and they found that in both groups they had improvement. So 68% of those people that got placebo, they didn't get anything, they improved. 77% with the antibiotics improved. Again, these are blinded. No one knew what they were getting. So you can see, even if you do have a bacterial sinusitis, chances are it's gonna clear on its own. Next slide. The next one we're going to go over is skin infections, and this is definitely a high yield area for improvement. Another one that has a lot of evidence that shorter durations are as effective as longer duration. This was a meta-analysis where they looked at 4 randomized trials, included over 1,400 people, and they looked at these shorter durations of either 5 or 6 days, compared to those same antibiotic courses of 10 to 12 days. And these infections that they specifically were looking at were more, I would say, simple cellulitis. So impetigo, or the group A strep, where you get that crust and stuff like that, or erysipelas, or that's where you get those clearly demarcated from the strep, group A strep infections. People that weren't having necessarily like abscesses, if they didn't have a lot of drainage from it, things like that. So not, we're not talking about you have a MRSA draining abscess. That's a scenario that might be needing longer courses depending on if it's drained and whatnot. But generally speaking, these fairly straightforward, what we see most of the time for cellulitis, the shorter courses did cure them. Next slide. And then I'm going to pass it over to Megan, who is the UTI queen, to talk about the UTIs, because there is a lot of literature around UTIs, and this certainly is one of the other areas that we could have a significant improvement towards.
Thanks, Kelly. Yeah, I love that I am now the UTI queen. That's my favorite thing ever. But so yes, moving on to the treatment of urinary tract infections. So since 2007, 9 randomized controlled trials have demonstrated no difference in clinical cure between using short duration, so that's 5 to 7 days, versus our historical durations of 10 to 14 days for complicated UTIs and pyelonephritis. I do want to note that that current terminology of complicated UTI is different from in these studies from what we currently use. And so I'll clarify what constitutes a complicated UTI in 2025, and thus in what situations you can use shorter courses for these patients in the next couple of slides. Next slide. So the next 2 slides, I'll detail some of the literature supporting short courses. And again, like Kelly, I'm not going to go over every single article. They're listed here for your reference. Next slide. I do want to note that some of the more recent articles or studies that have focused on shorter courses for UTIs have really focused on comparing short versus long courses with our fluoroquinolone agents that you can see here. And so our most robust data to support short courses are with using fluoroquinolones as a core regimen for our UTI patients. Next slide. And you might be wondering, does this translate to children? Yes, it does. There's some good amount of literature that suggests 5 to 7 days, or even as little as 3 days of antibiotics are acceptable to treat kiddos with febrile UTIs. Next slide. So circling back on definitions of UTI, so just a few months ago, the Infectious Diseases Society of America released new guidelines on the management of complicated UTIs, and this included a reclassification of complicated versus uncomplicated UTI. Uncomplicated UTI is now any infection that's confined to the bladder, that's regardless of sex and comorbidities like diabetes, for example. Complicated UTI is defined as an infection with systemic signs or symptoms present, like fever, bacteremia, flank pain, and any evidence of upper tract involvement, a la pyelonephritis. Complicated UTI also includes CAUTI, or catheter-associated urinary tract infections, as well. Next slide. So how do we treat depending on this classification scheme? So again, for uncomplicated UTIs, which are, again, infections that are confined to the bladder without a catheter, systemic complaints or symptoms, we can treat with a variety of different ways. We can do a single dose of fosfomycin, or one of my favorite things to do now is a single dose aminoglycoside that you can administer either IV or IM. We can give 3 days of double-strength trimethoprim sulfamethoxazole, 5 days of nitrofurantoin, 3 days of a fluoroquinolone, or 3 to 7 days of a beta-lactam. For complicated UTIs, again, fluoroquinolones are typically our go-to, and we suggest a 5 to 7 day course is adequate in these patients, and that is including patients who appear septic or have bacteremia present. That does not change the duration of therapy in that situation. 7-day duration is recommended if using a non-fluoroquinolone antibiotic, such as trimethoprim sulfamethoxazole, or our oral beta-lactams like cefpodoxime, amoxicillin clavulanate, or augmentin, or amoxicillin, rather. Next slide. So this is a great slide to summarize some of these shorter is better from specifically the American College of Physicians that published their best practice advice in 2021, outlining these preferred short courses. So starting left to right, for the treatment of COPD exacerbations and acute uncomplicated bronchitis, we recommend limiting antibiotics to 4 days. For the treatment of community-acquired pneumonia, 5 days is perfectly adequate. For uncomplicated UTIs, again, we want to do short courses. And for complicated UTIs, again, those courses are usually 5 to 7 days. I know in this particular guidance document, they recommended slightly longer durations. Again, this is available. This was published pre those new IDSA guidelines. We're recommending 5 to 7 days is adequate. And then lastly, for cellulitis, specifically non-purulent cellulitis, we should use a 5 to 6 day course of antibiotics that are active against streptococcal species and in patients who are able to self-monitor for improvement in their symptoms. Next slide. So we've talked a lot about how shorter durations can yield similar outcomes for our patients with certain infectious disease states. But there's also a benefit with using shorter courses in that we reduce the risk of antibiotic harms. Although harms associated with antibiotic use have been well established, there's really limited literature out there designed to quantify the risk of attributable harm from prolonged durations of therapy. So this is one of my favorite studies. It's by Curran and colleagues, and they analyzed over 30 systematic reviews of short versus long durations of therapy, and it included over 23,000 adult and pediatric patients. And what they found in regards to adverse drug events was that each additional day of antibiotics was associated with a 4% increased risk of adverse drug events, with severe adverse drug events rates increasing by 9% with each additional day. Additionally, with each additional day of antibiotics resistance increased by about 3% and secondary infections increased by about 2%. So if you're comparing treatment courses here, for example, if you're giving antibiotics for 3 versus 5 days, which is a very common, UTI duration of therapy, you can expect about a 10% increase in side effects by choosing that longer duration. Compare 3 versus 7 days, and you're nearly doubling that to 20%. So again, as I tell people, each day of antibiotics really does count, not only in helping to cure your patient, but on the flip side, preventing undue toxicity and antibiotic resistance. Next slide. So we recognize that these changes in durations of therapy can be quite overwhelming. There's lots of new data out there, and it can be hard to keep track of all of this. So we worked with our pharmacy task force to create some tools for clinicians that focuses towards these evidence-based guidance updates. And so the next two posters are intended to be posted in patient care areas, such as physician workrooms and in clinics near the site of prescribing, to nudge providers to, again, use those more appropriate durations of therapy. Our inpatient poster is seen on this slide. It covers some of the most common inpatient or acute care infections like we've covered, including CAP, VAP, intra-abdominal infections, bacteremia, pyelonephritis, and appendicitis with surgical source control. Next slide. And then we also have our outpatient posters, which again are more focused towards those conditions that you'd see in clinics or long-term care settings, including UTIs, pyelonephritis, sinusitis, otitis media, and cellulitis, as well as CAP. Next slide, please. All right, so moving on to some of our script pads. This script pad is available to you all, and it's our upper respiratory tract infection script pads, and they're designed to provide symptomatic management for a variety of infections like viral pharyngitis, otitis, influenza, COVID, and sinusitis. They include a description of anticipated duration of symptoms, as this is frequently a source of concern for patients who have symptoms that extend beyond 2 to 3 weeks. And we now have two versions of this, the original, which was intended for prescribers, as you can see on the left, and a new pharmacist version, which we partnered with Kansas Pharmacy Association to develop. So this tool for pharmacists is really designed to provide them symptomatic direction when a test result turns negative for a patient for group A strep or other viral conditions that are commonly tested in the Minute Clinic area. And it's in response to some of the state prescribing protocols for pharmacy that was passed by the Board of Pharmacy a few years ago. Next slide, please. This is the GU version. It's an adaptation of that common URI version, and this was developed after hearing from clinicians that they needed a tool to help patients who were suffering from chronic urinary symptoms and recurrent UTIs. I do want to point out that this script is not intended for primary UTI treatment, so anything that would necessitate an antibiotic. Instead, it's really there to serve as assistance with symptomatic GU control. So, for example, advising a patient on what can alleviate some of their symptoms when they have a confirmed UTI. It also provides some preventative strategies as well, like medications, dietary advice, and hygienic guidance, all of which are based off of national guidance. So again, really ideal for those patients who are struggling with recurrent UTIs or chronic pain. Again, we have a prescriber version and a pharmacist version. The pharmacist version on the right, again, designed to provide pharmacists with, specifically community pharmacists, with some of the tools and actionable guidance for patients who test negative for a UTI, but still need assistance with their symptom control. Next slide. And this is our most recent script pad created by Kelly. This one's really great. It's again focused on durations of therapy, providing recommendations in terms of antibiotics and their appropriate duration for some of our common infectious disease states that we covered today. These products are available and in finalized. We're working on sending out some of those links to you all. So hopefully when we have the meeting slides, we'll send those links as well so that you can have access to these script pads. Next slide. So we have a lot of provider-facing material. I want to flip it over to public material. And so we worked really hard to create this social media toolkit that is available to you all. It includes 12 graphic posts and several post options that can be customized to your institution and your own specific antibiotic-related information. Again, these posts are intended to educate the general public on shorter is better and other core antimicrobial stewardship principles. Next slide. So over the next couple slides, I'll just highlight some of those posts because we really enjoy them. They have a lot of great graphics. So for example, this is again focusing on shorter is better in the surgical procedures area, as well as bacterial pneumonia. Next slide. This one is focusing on, again, shorter is better and dental stewardship as well. Next slide. The One Health approach on the left, and again, my favorite, the treatment of urinary tract infections. Next slide. Everybody's favorite, sinusitis, how to treat it, when to treat it. Next slide. And then lastly, again, skin and soft tissue infections and reviewing antibiotic resistance. Next slide. So that is it for our presentation today. Thank you all for joining, and we'd be happy to answer any questions.
So at this point, you can take yourself off mute. If you do have a question, just use that raise your hand feature so we can not have everyone's talk at once, or you can place questions into the chat. I see that there's been a couple. Kelly, were you able to respond to both of those that were earlier on?
Yeah, so Mindy asked about that study of the CAP that had over 18,000 people that were studied, and if it included elderly people too. So it definitely did. It included older adults, and then it also included children as well. The one population that really wasn't, in that analysis is people that tend to have a lot of bacteria in their lungs. So if you're talking about like someone that has cystic fibrosis, someone that has chronic bronchiectasis, though it was really more, non severe pulmonary comorbidity in pneumonias, but it just certainly did study other people that have many comorbidities in those. And then the other question was about the dose and whether it seems like maybe the resistance, the pressure to select resistance is perhaps higher with the dose, depending on the dose or the duration than the dose. And both of those are very important factors. There does seem to be more suggestion in the literature that the duration might be more, perhaps a more critical factor than the dosage. But I will also let Megan, who's our pharmacist expert, weigh in if she feels differently or has any other things to comment on that.
Yeah, that's a really great question. I would say definitely duration as opposed to dose in my mind is a driver for antibiotic resistance. It would be curious to see how some of the dose variation might affect it, but I think dosing is very standardized. And so it's not like you're going to be using an off-label dose for most of these patients, whereas duration of therapy can vary quite widely for common infectious disease states. So that's where I'm thinking that there would be less variability in that dose versus duration being more of a driver, given that patients can receive very long, prolonged durations that might yield, again, that increased risk of resistance.
I did receive one question directly. As far as the shorter duration, with most antibiotics, is the dose still the same as what it would have been with those longer durations?
Yeah, most of the time the dose is still the same. So it's still the standard dose that we're used to prescribing. Really, it's just focusing more on cutting down those unnecessary long durations. I can't think of any, Megan. I can't think of any dose increases. Yeah, for any of
No,
the conditions.
same dose.
One thing also I will add, I'm like impressed that we finished so early actually with having 40 slides. One thing that we didn't also talk about, I debated whether to leave this in, but I thought it was getting too long, was the bacteremias. And so as Megan talked about, or, there was one of the social media that has this for it. But that is another area that could be probably cut down too. So especially if you're getting like, say, a gram-negative bloodstream infection from someone that has a pyelonephritis or a UTI or an intra-abdominal infection, generally speaking, 7 days is adequate for that. Of course, there are certain, bloodstream infections, like we're talking, Staph aureus or candidemia. Those are not those types of scenarios where you cut it down, but your typical pyelo that's associated with a bacteremia, you just treat the pyelo.
Absolutely. That's now encompassed in that complicated UTI definition that if a patient has a bacteremia, you can still treat them for 7 days. But like Kelly alluded to, the most amount of literature in this space is focused on gram-negative bacteremia secondary to urinary source, in which we have multiple randomized controlled trials that suggest that 7 days is just as effective as 14 days for that patient population. And the most recent study we have is the BALANCE study that was released. I believe it was last year now. Time is going quickly, so it might have been this year, it might have been last year. But anyway, it was published in the New England Journal of Medicine, and they were pretty broad in terms of their inclusion criteria. So they included not only gram-negatives, which we at this point feel fairly comfortable treating for short courses, but also some gram-positive bacteria as well, and found, again, no differences in terms of shorter versus longer durations. And they also, which a pharmacist love, they included a good number of patients who were switched to oral therapy as well, which is also very positive for us who are trying to find ways to get a patient out of the hospital safely, so that they don't have to stay for IV therapy to treat their bacteremia.
Are there any other questions? So we actually have time for questions. Okay. Well, as I am not seeing any additional questions, I want to thank everyone for joining us today in recognition of U.S. Antibiotic Awareness Week, and especially want to give a special thank you to our presenters for sharing their expertise. Just as a reminder, if you would like to receive a certificate of attendance, please indicate this on the post-event evaluation, which should pop up when you exit the webinar. And then we also ask that even if you don't want a certificate, please do provide feedback on that survey, just as that does help with deciding future presentations and information to include. So thank you again for your continued commitment to patient safety and to advancing antibiotic stewardship. So we want to thank you. And that's all I have. We can stay on for a few minutes in case someone has a question, but otherwise, this concludes today's presentation.